Todd Rogers from the Kempton Group, and I have the privilege of introducing our panelists today. We have 3 employer panelists and then a facilitator of healthcare, and they're going to talk about free market healthcare solutions focusing on pharmacy and specialty pharmacy solutions. So beginning, we have Drew Jacobs with Adfitech from Edmond, Oklahoma. We have Taylor Pitlik from Rhinelander, Wisconsin, and Derek Francis from Hospice of Wichita Falls in Wichita Falls, Texas. And then Steve Boyd from Natchitoches, Louisiana. And Steve and his wife and his father-in-law, about over a decade ago, saw a true problem in the way pharmacy benefits were being delivered to employers, fraud and waste, and all being clinical pharmacists themselves. They wanted to create solutions for that, and there was a lot of strange and twists to the road, but over this time they've been able to develop a very successful company with growth that enables employers to have a transparent and pass-through pharmacy program for their pharmacy benefits. So with that,
thanks, Todd. You bet. I'm a little worried we'll get a little feedback here, but okay, looks like we're okay. So it's a pleasure, thank you, and looking forward to sharing our stories with everyone. As we transition a little bit, again, I appreciate the nice warm introduction. I am a pharmacist, and I've been a pharmacist for about 22 years now. It's hard to believe that. But through that process, I played several roles in my career. I was an academic for a while, and then owned and operated several pharmacies, and then, as Todd said, migrated into managed care. That has, without a doubt, been some of the funnest aspects because we get to serve employers who are obviously serving employees, and being able to provide solutions to them to be able to provide better health care to patients has really been rewarding. I do personally kind of miss sometimes the interaction with one-on-one with a diabetes patient or hypertension patient, but it has definitely been an area in which I've enjoyed. So as he mentioned, we have 3 distinguished panelists that will be sharing kind of our story of how we've worked together. No big surprise, there's numerous problems in healthcare, especially associated with prescription drugs. You'll notice that generic costs over the last 5 years have risen 350%. Remember, generic drugs are supposed to be the solution to expensive drugs, and here now we're finding behaviors in the manufacturer arenas in which they monopolize different drugs and then they raise the prices on them. Probably the biggest issue that we have in the marketplace is specialty drugs, and we'll be speaking to a lot of the solutions that we've done together to help lower those costs. But the reality is they're expensive, and the manufacturers benefit greatly from limiting the ability to distribute those drugs. They benefit greatly by creating programs that help get that drug into the home of the member using coupons, and obviously by using something called rebates, they're able to manipulate formularies to ensure that their drug is successfully put on the wagon in order to be paid for or reimbursed through the PBM. Notice that we also are seeing an overall increase in brand drugs as well. So the challenge here is that how are we going to continue to afford prescription drugs? How do we continue to ensure that these benefits are rich for employers? And so at Southern Scripts, a company that my wife and I started again approximately 12 years ago, we begin by really focusing in on a simpler way to administer medications and price those medications. First and foremost, we're a pass-through PBM. What that means for those of you that may not know that term as well, meaning that when a patient walks into a pharmacy and they hand that prescription to the pharmacist creates a transaction, and at the end of that transaction, they're owed $100. Okay, and so we pay them $100, and then we turn to Adfitech and we charge them $100. Okay, now what goes on and what's been happening in the world of PBM for the last 25 years is the pharmacies paid $100, but Adfitech is charged $125, and that markup is retained by the PBM and is a profit center for them that's completely undisclosed, and you as the employer are unaware of that behavior or that extra revenue that goes on. And then on top of that, the same thing will happen with rebates. And let's say that for the Hospice of Wichita Falls would say have $100,000 worth of rebates associated with their brand and specialty drugs. available from the manufacturers, what would actually happen is that they would only receive about half of that, and then the PBM retains that other half. We don't practice that. All $100,000, all manufacturer dollars are passed to the employer, so that way they're purchasing the drug. Why wouldn't they get all of the rebate dollars? And so that is a significant difference between our model as a pass-through transparent PBM as you would compare to, say, an Express Scripts CVS or an Optum, which is more of a traditional type of PBM model. Well, one other thing, and I have to credit my wife, our CEO, she was really adamant that we were going to have one source of revenue. And so it makes it incredibly clear on what services we're providing and what we're charging for that. And so I'll ask a loaded question, and it is a loaded question. Those of you that have a PBM today that's not a pass-through PBM, what are you paying them for their service? Yeah, that's what, yeah. And how much is that?
Too much.
Yeah.
If you don't know, if you're not being charged a fee, that fee is somewhere hidden in that.
That's exactly. That's it.
75% gross margin. Never touch.
Yeah.
There's my guy.
Never fill.
Yeah, I love it. And you know, the last discussion we had, the quote that came out, what industry do you not know? And so these three panelists know exactly what I'm charging them and what they're paying me for our services. And so at the end of the year, they can say, well, did I enjoy Steve? Did I enjoy Southern Scripts? Did they do a good job? Did they make their promises come true? Did they have a sense of urgency when we have a problem? Did they bring us new things to help us control costs? And was it worth the 20 grand they paid us? And that's what we believe is a better model. Okay. And then I think finally, everything's transparent. So all of the data is available. And I'm going to share, based on some of the comments, our industry is very frustrated the fact that you can't get access to data. In our case, everything's available. Nothing's proprietary. If you ask any question at any time, we will answer it. It won't end with, I'm sorry, that's unprivileged, all right, or privileged information. So we work, everything, again, is available. So just a little bit more background on us. We're very member-centric. We have had the success of a Net Promoter Score of 89%. That may not be a formula that you're used to or criteria, but the standard industry average on retail type is around 75. And so in our industry, that's a very, very good score. We do own and operate our own call center, and we're very proud to say that a person picks up the phone. They will have a Louisiana accent, so be ready, all right? But they're very, very strong, service-oriented folks. And then we have a 97% first call resolution in that call center, many metrics to go along with. We're available 24/7. And I'm also proud to share with you an organization called PUT, Pharmacists United for Truth and Transparency. You may not have heard of them. Their website is truthrx.org. They're a little grumpy pharmacists at times, but they're the only organization that is certified whether or not a PBM is transparent. And so we received that privilege a number of years ago. And so I always recognize them. If you may want to search them if you're looking for a PBM. So with that being said, I'm going to introduce a program that we brought to the market about 7 years ago called Variable Copay. And then we're going to show you some of the outcomes of that program. We'll let our panelists speak to the experience of that and maybe some of the other programs that we have. This program here, again, is called Variable Copay. And though, if you remember the old days, the doctors used to hand samples out to members when they were in the patient room. Well, now what they do is they give them a coupon card. And what that coupon card does is picks up the $200 copay, the light blue bar there, an A, so that the member can walk away from the pharmacy and not pay for the drug every single month. So they get the entire drug for free at no charge to them, and they get $200 credit to their accumulator file. So what we did is we recognized that that coupon was worth $1,000. And so we changed the copay through the summary plan documents from $200 to $1,000. That means that the coupon comes in, picks up the $1,000. The member still gets the benefit of a $0 copay, but notice the cost shift that occurs as an $800 savings to the employer. Right? And because the member didn't actually pay it with their own money, we do not accumulate. And that, Yeah, we do not accumulate that to the out-of-pocket. We only accumulate specifically what the member actually paid. So with that, I think we'll go ahead and let Mr. Derrick speak to his experience with Hospice of Wichita Falls.
Can I ask a quick question before we
Of course, yeah.
can we ask questions?
I think this is a great time to ask a question.
How does this compare, like, or how does your PBM or past your PBM compare to GoodRx?
Yeah, so, yeah, great question. What was your name? Toby. So Toby, GoodRx is not a PBM. GoodRx is a discount card. And so there are numerous good discounts cards in the marketplace. And what that does is allow someone that doesn't have insurance or chooses not to use their insurance to give a discount card. That discount is very good if you're comparing it to an Express Scripts price. Because remember, I mentioned Express Scripts is marking up the claim $25. GoodRx is not doing that. GoodRx is giving you a stellar discount at Walgreens. Because I don't mark up the claim, my discount's going to be the same as a GoodRx card, and then it'll also apply to your insurance.
Okay, so basically it is an alternative, like, even though they're not a pass-through PBM or PBM at all, GoodRx would be, sounds like equivalent.
No.
Yeah, so GoodRx is going to get you a good price, but you're going to pay 100% cash, and you're not going to get any credit towards your deductible, your copay, or it won't be connected to your health plan. It's completely separate. Whereas what I'm saying is that our discounts that we have with the pharmacies are equivalent to a GoodRx, but it's part of your health plan, and whatever you pay at the pharmacy, you're going to get credit towards your deductible and accumulator. Okay.
It would be like an office visit, copay, kind of an experience. The member goes in, they pay their flat fee, whatever it would be, versus the GoodRx says, we'll give you a 10% discount for using our card, or a 20% discount, but you pay the whole rest of the balance.
Yeah.
So,
And we can talk a little bit more detail
it's a good
afterwards.
search engine, though.
It's a great tool. And,
I use it a lot to say, someone mentioned the drug, I use it a lot.
and,
The
and
ballpark price of that drug.
yes, ma'am. And towards the end of the presentation, I'll be sharing something what I would call GoodRx on steroids, in which we created and launched 2 weeks ago. And so we'll kind of, I think you'll enjoy that. So, Mr. Derrick, Ms. Francis, would you like to mention?
I need a microphone. Oh, there you go. Thank you. So, can you guys hear me? Okay, good. It's weird because everything's going that way. I can't hear it up here. So yeah, I'm Derrick Francis. I'm the CFO for Hospice of Wichita Falls. We're a large nonprofit, about 2.5 hours northwest of here. We are the 17th largest hospice in Texas. So that includes all the big metro areas, the Solarises, the Utah hospices. We've been around since 1985, and we serve 12 counties in northwest Texas. So, and we'll be in the main ballroom after this, so I'll keep it brief. But like many of you, we were just up against year after year of incredible increases with our fully insured health plan, to where we definitely had to do something different. So. Speaking to the pharmacy benefits specifically, obviously the two largest costs of any health plan are pharmacy and catastrophic. And I would say we've had an overwhelmingly positive experience with Southern Scripts. I don't know. Would you say that your Net Promoter Score? I don't know if that means your ability to get pharmacies in network, but definitely we've seen great success with that.
The Net Promoter Score is a national criteria that evaluates customer service levels as a whole. It wouldn't be as connected to pharmacies, network pharmacies, but it just kind of evaluates in a general way of how that entity is performing as far as customer service. So,
Right.
yep.
But from the employee experience side, I mean, just speaking for me personally, who takes several generic drugs, I've seen my monthly costs go down even below what I was able to get previously with GoodRx. We were on a high deductible health plan, and so it paid zero, up until we met our deductible. So it was definitely in my and all the other members' best interest to shop around and use those coupon codes. And I'll use my stepdaughter as an example. She takes ADHD medication, to help her in school, and it's gone from which code we can Google the best every month, because it would change from month to month. 1 month it might be GoodRx, 1 month I can't even remember the names of them because I don't have to use them anymore, because it's a $10 copay each month. And so it's,
With other script.
yes, And so, I can speak definitely from a member side, it's great. And then, from being the plan administrator, you're correct. Any information that we've asked for, we write our check to Southern Scripts, or Kempton writes it for us every 2 weeks. And I get a report of what all those drugs were, what member they were assigned to, the cost the plan paid, the cost the member paid, and it's completely transparent. So.
Right. And I think on this particular slide, this is actual data from Wichita, Hospice of Wichita Falls. You'll notice it's dated from November to April of 2022, so it's very current data. And these are claims, and these, you might recognize some of these drugs are brand and specialty drugs. Some of them are with strokes and diabetes, and quite a bit of diabetes actually. In this particular case, that variable copay program that I mentioned saved Wichita Falls $9,372 over just a quarter. So on an annual basis, that's going to be approaching, around $30,000 to $35,000 of savings for them. And any drug that comes out, a brand or specialty drug, we have a program in which we make sure the member has a warm experience transitioning into that. Another component of what we do is something called clinical management. In this particular case with Hospice of Wichita Falls, you'll notice that there was $49,000 of savings associated with managing prior authorizations and step therapy. Prior authorizations is a four-letter word to some of us because it's very challenging at times to work through that process. But what you'll notice is that our approval rate is actually 55% of them are denied, and where I guess that's around 45% are approved. What that means is our clinical team representing Hospice of Wichita Falls said that the providers that were writing the prescriptions, the evidence to support that prescription wasn't necessarily as strong as using an alternate therapy, maybe a first-line generic therapy first. And so under this model, the cost avoidance of requiring a different therapy first that does the same thing and the same outcome was, again, savings, a cost avoidance of around $49,000. So with that, we'll transition a little bit over to Ms. Taylor. Taylor, do you want to introduce yourself?
Sure. My name's Taylor. I represent Pitlik and Wick, which is a road construction contractor in north central Wisconsin based out of Eagle River. And this is our first plan year that we are with Southern Scripts, and have been seeing kind of some cool results just in our first year of transitioning. I don't know if you want to go to the... So one thing that's really cool I'll talk about first is the testimonial in the bottom corner there. And it's from one of our members that their dependent saved, $3,800 just by switching to a mail order through Southern Scripts. So they were actually on this medication with the previous PBM that we had, and just by switching with them and routing through their mail service, there was already a huge cost savings. I don't know if you want to...
That would be the spread. So in the previous arrangement, the PBM owned their own mail order facility, which we do not do that. We don't own our own mail order facility. And they were marking up the claim. They were forcing that prescription into their mail order pharmacy, and they were marking up the claim $3,800 to profit off of that, which was unknown to her organization until we came in. Poof, it was $3,800 because we passed the price through.
Yeah, so that's cool whenever you can have a member, see that directly. They were just, they told everyone, which is great. That's, help keeps the ball rolling and people talking and looking for the programs. Another thing that's really cool about Southern Scripts is what he talked about with their transparency, with their data and things like that. That allows us to have all these other prescription vendors work within our plan. So we use Script Sourcing, which is an international pharmacy vendor, and we also use Scripta. So Script Sourcing, they'll take one of our claims and they'll say, hey, we can route this through an international pharmacy and get the prescription for cheaper. So a couple of our members have been able to utilize that. And then Scripta, they actually, we're just kind of working on that now. But same thing, they kind of mine our data and they print out these reports saying, hey, do you know you take this drug? There's, drug A, you can also take drug B, which is the same thing, and you can save X amount of dollars. And it's on this little report that you can take to your doctor and obviously work with your doctor to know if it's a good switch or not. But just being able to kind of use all three of, Southern Scripts, Scripta, and script sourcing. Very hard to keep them all straight, but kind of using all three of those to work together to really make our pharmacy part of our plan robust has been life-changing. So.
Are all three of those under the Southern?
Yeah, I'd like to kind of clarify a little bit. And so she made a remark. She said, Southern Scripts is our PBM. And then she followed that up with and said, they allow us to work with other vendors. And she has named two vendors, one of which is on the slide called script sourcing. We see a lot of value in script sourcing. She mentioned the piece about international mail and how they're able to find alternate sourcings of drugs. So we are very comfortable bringing in a solution like that because, again, we're not profiting off of the claim. We just get a transaction fee. So as long as we're working to a lower net, a vendor like this is a great tool to help lower their costs. And you can see that there's a variety of different outcomes here. In November of 2021, they had two unique members that ended up saving a total of $2,100 through that program. So it's an added program on top of what we were doing. Okay?
The script sourcing is international.
That is one of...
Is it the mail order?
This would be international. Whereas the testimonial down here in the last part of the slide is what she was speaking of, is a mail order pharmacy that's within our pharmacy network that was utilized. Yep. And we tried to condense the slide so I can see how that could be a little bit confusing. So with that, Mr. Jacobs, President of Adfitech, would you like to say a few words?
Thank you, Steve. So I'm the president of a company that does mortgages. We audit financials, audit loans. So my day job is running a company. However, when we decided to look into changing our insurance piece, I kept it. I have HR, I have a CFO, I have chief legal counsel, but I was pretty passionate about I wanted a self-funding plan to be the best possible, for the best possible service for my employees and to save some money in the boot. Been following the Oklahoma City, the J. Kemptons, the SCOs of the world, the pioneering in Oklahoma City, so I was kind of in the hot pocket of this new revolution. And one day I was out to eat with my board of directors, and I took a little bit too big a bite of steak. Maybe I'd been drinking. And the steak got lodged in my throat with the board of directors. So I ended up in the hospital with a lodged piece of meat. Long story short, they found out I had GERD. I had the great opportunity to go see a surgeon, stuck a tube down my throat and blow up my esophagus. They said, well, you're probably going to have to get on some medicine for controlling your acid. Okay. They gave me a generic, nickel a piece. Kind of made my stomach upset. Not going to get into details. So I said, okay, there's other options. So they gave me a sample. No idea what the sample is. I take it home, I try it. It was okay. Went to get it filled at the pharmacy. They declined it. They have to run it by my insurance company. Self-funding. Okay, $1,800 a month for a GERD medication. How many DPCs are in here? So before I talk about drugs, I talk about DPCs because I don't want a savings of $1,800 or a $100 coupon on $1,800. I want a savings back to the nickel that won't even show up on this chart. So it kind of was the straw that broke the camel's back. I'm going to become a member of a DPC and see what this is all about. Walked into his office, told him the story. Nickel, $1,800. He laughed at me. He goes, well, let's see. We can change your diet. We can change some of the things you're doing. And we have 20 different generic drugs that we can test before we get to the $1,800. So I like Steve's numbers up there, and I like that I can save when I have to get from $46,000 and I can save down to $44,000. But I really like it when my DPC doc goes, oh yeah, that's a nickel.
We should have put this slide on yours because that's what he just described, clinical management. And I should have ran the data for you there, Drew, on what.
So
we've done
your
there.
problem, Steve, is you don't have that data. And there's a lot of complaints about DPCs and data. But, guys, a good DPC that does not want to report is on my plan anyway. Because my DPC goes, I quit normal medicine because I want to practice medicine. I don't want to do reporting. I don't want to do coding. I don't want to do all that stuff. I want to practice medicine. So because I kind of am the president of the company and I get to kind of tell them what we're going to do, and the board of directors almost saw me die, it gave me some, ability to negotiate with them. So it's like, guys, just trust me. This, number one, it's keeping me alive, and number two, it is saving us money. But I don't have all the analytics like the chart.
Yeah.
But this is a parachute. Sometimes you have to have a parachute, and when you have to put on the parachute, you want the best priced parachute you can get that's a really good parachute.
I think I would just like to throw out a suggestion. The DPCs that raised their hands, we would be very welcome to the concept of seeing how we could work together and use that data and create incentives within the plan that help the DPCs take advantage of prescription benefits in a way that controls costs but yet provides great therapy. I'm fortunate enough to have we have Whole Foods as a client, and they have 2 DPC clinics, one in Austin and one in San Bernardino, California, and we've been running this project for about 6 years now. And that's what we do with them, is that they have their specific formulary. When a doctor from the Whole Foods clinic writes the prescription, it's a different copay because that physician was used. Be very open to working with any of you around creating that for your employer groups. And Drew, I'll be following up with you to see if we can do that for you.
So you asked about GoodRx. It's on my phone. I use it every day. I use it for 2 reasons. Number one, I use it to keep Steve honest.
Right on. Trust and verify.
Yeah,
Trust
that's right.
and verify. And number 2, when I'm sitting around watching TV at night, all these commercials come on with drugs. It's like, oh crap, do I have one of those hit my plan? Hit GoodRx, and it's like, oh, I hope not.
We just had one of the thyroid, that the eyes bulge. Have you seen
Oh,
those
yeah.
commercials?
I've seen the commercials, yeah.
Maybe you haven't seen the price ticket on that yet. We just had one. Blinded by it.
Well, and that's a pretty good segue.
Plus $1 million, just so you know.
We've got about 15 minutes left, right? So that's a good segue to kind of talk about, that's what we've been doing together, and that's kind of our core product that we offer. Would you be interested in seeing what else we offer and where we're kind of going as an organization?
When you say that's our core product, what is that?
Yeah, so Toby, our core product is pass-through pricing, pass-through rebates, clinical management, and variable copay.
Hey, Steve, mate, one more thing. So Sudafed, it's not a prescription drug. It's the most controlled drug there is in Oklahoma because of all the meth labs, right? You can't hardly buy this stuff anymore unless you're making meth and they get it somehow. So you go to Walmart, you can't get it. GoodRx, this box costs $3, right? So what I have to do is get my DPC writes a script, and I can get it, even though it's over the counter, I can get it cheaper as a script from a DPC. But even better, Amazon Prime Pharmacy, you know how much this costs? $1.03 delivered to my house.
You can get it in Costco for $2.50.
Yep.
Is that, so that's, the Amazon pharmacy is different from Southern?
No, ma'am. So Amazon pharmacies on our network. We have 68,000 pharmacies on our network. Amazon, PillPack, those pharmacies are preferred in our network. Yeah, and so what my job is that Drew tells me I want this to be covered on the plan because I'm going to run through a script, and we program it so that when a member goes to a DPC, gets Sudafed, it'll go through the plan at that discounted rate of $1.99, it sounds like. Yep. Yeah. So
Well, who knows?
To reinforce your question, Drew, this is, or Toby, excuse me, this is our core product, which typically comes in and saves $23 a prescription. Again, when we replace a traditional type of PBM, like an Express Scripts, CVS, Optum, maybe a Prime, okay? And that's, again, variable copay, pass-through pricing and rebates, and pricing and rebates, and that clinical management that we talked about. Where we're going in the industry, I have to take you back to the very first slide. It's tough out there. These new drugs, we just talked about the thyroid drug, they're continuing to come out. When I was training to be a pharmacist, a drug cost an average of about $150 when they came out. Well, now it's like $3,000 a month. And so the way the market's put together, that's what until rebates are considered illegal and not, and they're considered a form of kickback, I don't believe the industry is going to change. We're going to continue to see this elevation in prices and so forth. So for employers who want to be more progressive and be more assertive in how they manage a plan, we offer them additional services. And this can be medical tourism or international mail. That can be something called Telesaver, in which you can get your drugs through a physician who's a 340B qualified physician, which comes with a 65% federal discount. We also do something called PAP, Patient Assistance Services, meaning that low-income employees that would qualify to receive free drug from the manufacturer, meaning we evacuate that drug off of the plan and the manufacturer gifts it to the patient. So we allow these services to take place within the current plan design. Now, these three employers are not currently using those, but I'm kind of marketing to them right now that we have this new service together, and it's called RX Compass. And you'll notice the PBM's in the middle. And we have all these gears, kind of like the inside of a watch. And so what we're doing is owning the relationship that a patient would go through in each one of these services. And we're asking the question, if you're prescribed a drug like Humira, which one of these pathways or gears would make sure that the employer gets the cheapest price? And so then we work with the employer to explain to them that you can get it through international means for this price, which is significantly different. Would you like to adopt and change your plan design to where you have this available to all of your employees? Okay? Well, what's really fun, and with the discussions around GoodRx, we created something called real-time pricing. And I believe it's GoodRx on steroids. And if you don't mind, I'd like to show it to you. Okay? All right, so I'm jumping on the website, and all of you that have an iPhone, you can put this into your iPhone and you can search it. It's myrxcompass.com. Yes, I'm sorry, any handheld device. So. Oh shoot, it didn't pop up.
I think that they said the internet.
myrxcompass.com. I can't show the internet. Well, that's a bummer. Okay.
We'll look at it on our
So, yeah. Well, let's do it this way. So if you bring up your phone, you can each do your own individual search. But what RX Compass is, and I'll bring up the gears here again and show that. Okay, you can see this. All right. So what myrxcompass.com is a discussion around all of these different services. Again, we've already talked about variable copay. Telesaver is the ability to get a drug through 340B discount. And you do a televisit with a physician that's at a federally qualified health center, and then that drug now is discounted approximately 60%. International specialty means that this drug can be sourced from Canada. It comes from the same manufacturers. If a patient volunteers to have their drug sourced from Canada, they can receive it for approximately a 50% discount compared to the prices in America. International brand is the same thing, just brand drugs versus specialty drugs. And then this thing called patient assistance that I mentioned, that if a low-income patient has a specialty drug or a brand drug that a manufacturer offers free assistance, we assist them in qualifying for that, and then they get the drug for free. So what the website that you're on right now, when you click on real-time pricing,
Make me put my name in.
Yep, you gotta authenticate. So, and you can just, if you're not comfortable with that, just put in an initial or something. You can put a fake email address in there. But what it does is that it allows you to take any drug, the ones that we talked about, put it into the system, and it will tell you not only what the price is at Southern Scripts, it'll tell you what the rebate available is at from the manufacturer, it'll tell you what the coupon amount is with variable copay, and then it'll tell you if it's available internationally, and it'll tell you if there's a patient assistance program available, and if it's available through TeleSaver 340B. So that's what I mean by on steroids. So not only do you get a pass-through price at a Walgreens, Rite Aid, which GoodRx does, you now have access to what the rebate is. All right? Now, as a patient, that might not be of interest to you. But as an employer, to have access to a transparent rebate, no one in the country offers that. We are the first. And now an employer can make a decision, should I put this on my formulary or not? All right, because I have such a good rebate. Or do I want to go in a different pathway? The other thing that it does is it gives you openness to, is it available other ways other than just through the PBM? Can I get it from Canada? The Canadian prices, again, are 50% off. So that puts a little pressure on the employer to decide, do I want to give this opportunity to our members to be able to save? When they go through these pathways, the member's copay essentially is going to be zero. Why? Because the employer wants to incentivize those patients to use these services because it lowers their cost by approximately 50% or even more. Okay? So I'm hoping everyone's tracking with me here. I'm sorry I couldn't bring it up, but hopefully you're able to price one yourself. Yes, sir. Mr. Todd? Yeah. So any questions? Yes, ma'am.
So with you guys integrating all of these years now, the comparability to this with Southern Scripts and there's other outsources like Sharp.
Sure.
How is this comparable to what Sharp?
Yeah, so you've got script sourcing, Sharks, Payer Matrix, Paid Health, Canna RX, RX and Go, RX for me, RX for you. There's many of these programs that you described. Those programs are independently owned, and we are welcome working with them, just like we talked about with script sourcing with Teresa. What this is, we own all of this. And so the experience to the member is a more or less convoluted experience because the employees of Southern Scripts are managing this, and the patient has kind of one-stop shop now.
Right, so my question would be is, now that you've integrated this piece, can this now do exactly like outsourcing to international and everything like Sharks, where I can maybe get rid of Sharks if I went that route and wanted to go?
So ultimately the answer to your question is yes. Now, I want to make it clear, we like Sharks. We think they bring value, and I think that you have to do your due diligence on what is the best option for you. We're friends with them, and so the last thing I want to do is say, leave Sharks. No, they...
So now it's like the international mail and all this.
Yeah.
Equivalent.
You'll...
Utilize this one.
The answer is yes, and so you do your due diligence to decide if this is a better option for you, or Sharks the where you'd want to stay. I just want to stress to you that we're agnostic. If an employer wants to stay with Sharks or another vendor, we welcome that. But we do have this available if they want to make a change.
Can you integrate an outside vendor into your PR model here?
We're fully integrated with over 15 different vendors, and I've mentioned most of them today. Yep. Yes, sir.
One question. Even though you gave us this app, which we can see the pricing, if I'm not on Southern Scripts, I can't do it, right?
That would be correct. So RX Compass and this product is really for you as a resource to say, what is my price today with my other PBM, and could I be getting it cheaper if Southern Scripts was my PBM? And so that's what you're at in that stage. Then if you were to come on board, now this resource is just helping you manage the claims because we'll be driving them to these different services. So it's more of a marketing tool for you at this point and a resource.
Well, I'm on Medicare, so it won't work.
Yeah, well, yes, sir.
I'm a DBC owner. We have 4 physicians and 2,500 patients in North Idaho. We're also a dispensary. We have pharmacy privileges in Idaho. The question for you is twofold. One, we wholesale meds. Are we able to interact or engage with Southern Scripts directly for purchasing on behalf of our members? The second is most of our members are health share. Are health shares engaging with your company to be able to direct their members?
Yeah, so good question. It's very nice to meet you. So we work with several DCPs that provide their services directly to self-insured employers. The only opportunity that I believe we would have to work together would be if you have self-insured employers and we became their PBM, then you and I would work to create a formulary and different strategies that are in your belief model as well as the employer's goals. And we would be very flexible in creating a pharmacy package that all three of us are working in harmony together.
We're going to touch on that a little more at 10:30 in the big room.
Yeah, and thank you. We do need to curtail questioning for right now. We've got a little scheduling that went in. We'll, have our heads if we're going to call down. So we're going to comply with that. One comment, I think, Chief Kempton.
Thanks, Steve.
Oh, hi, Jay.
Thank you all, panelists, everyone. As I was sitting in the back, I did have 2 points I think are very, very important. And one of them was one that Drew was making. Getting the best pharmacy pricing is obviously hugely important, and Southern Scripts is a great partner there. But I think where also Drew was coming from is, if you have a DPC, DPC's priorities are aligned with the patient. Avoiding the claim is the best cost saving you can ever.
Amen.
Yeah.
But not avoiding so you're not compliant. Well, not taking.
And then the other comment I want to make, again, since Steve has not hitched his revenue wagon to ever increasing prescription costs because he pays a flat amount, because of that, he has a flat fixed rate for his revenue. And when you compare that to, say, an Express Scripts, it's going to look higher. It is higher. But just like on those savings slides where you saw these savings, and it was, he mentioned a couple of times, and well, that was just a markup on the claim. Well, what that PBM has essentially done has taken their fixed cost and blended it into the claims cost. And so I hear a lot of consultants, probably not any of the smart consultants that are in this room, but I hear a lot of consultants will either say to a good guy PBM or a good guy TPA, your fixed costs are too high. And it's because we took all of our revenue out of the claim. We're aligned with the employer to drive the cost down. And so all of our revenue is on one line item. It's not scattered through.
Before we were required to be transparent, we were transparent. That's right. And now we're all supposed to be doing what Jay just described. So.